Hey everyone, welcome to KSSP Podcast. I'm Spencer,
And I'm Katie.
and today we're going to be talking about stroke. So, I made a little PowerPoint here, so I'm gonna share my screen. We're gonna be talking about stroke, mainly ischemic today. Some other day we can go more into depth about the other kind of strokes, and I'm not going into super depth on ischemic because obviously with ischemic strokes it's going to depend on where the clot is that can kind of determine what kind of stroke it is, but we're going to try to keep it a little simple today, even though I may go a little in depth. But okay, so we'll start with an ischemic stroke, just kind of a short definition. So ischemic stroke is a lack of blood flow, and that is going to be so when arterial blood flow to the brain fails to meet metabolic demand, resulting in cell damage or death.
So I have a
So
question.
yes.
What are, just so that we know, like, what are the other types of stroke? Just like, what are they called? If you know.
So it kind of like the main classifications of stroke are going to be ischemic, which is where there's a blockage, and then hemorrhagic, where there's like a bleed. But hemorrhagic, there's like different kinds of bleeds. It depends on where in the brain. Oops.
Yeah.
um, is going to determine what type of hemorrhagic stroke it is. But the simplified is that there's ischemic, so that's when there's like a clot. So if you think of like maybe a drain pipe and there's something blocking the drain so the water can't drain, that could be like an ischemic because then the blood flow isn't able to get to the brain to give it oxygen and nutrients. And then the other type, hemorrhagic, we were always taught in nursing school to think of the brain like a box because we have our skull up here that is not, what do I want to say? Like it isn't malleable, I would say.
Oh, okay. Like plastic?
Yeah, so it's very rigid. So
Oh,
when something starts to bleed, it can't expand. So
right.
instead of
Okay.
it like just increases the pressure in your brain and then that causes injury and that can obviously lead to death. Any type of stroke can lead to death. So strokes are obviously a medical emergency.
Yeah, for sure.
So we'll talk about some signs and symptoms that if you're having these signs and symptoms, you'll want to get to the hospital as soon as possible. And an acronym that we were always taught is FAST. So that's going to be if you notice either on you or anyone else, that could be facial drooping. So, like, a lot of times their mouth will just kind of like, if you ask them to smile, they won't be able to smile. Like, one side will like stay down. I don't know if that, and it
Yeah.
can be like an eyebrow if they can't raise their eyebrows. Basically, any sort of where they're not able to move their full face, we consider drooping, facial drooping. And then arm weakness. So if one arm they can't like lift up or move at all compared to the other arm. And then there's speech difficulty. So if they're having trouble kind of talking, like if their words aren't making sense or what they're saying isn't really matching up with what you're talking about, that is definitely a big sign. And then the T stands for time to call 911 because again, a stroke is a medical emergency, so you need to get to the hospital as soon as you can if you notice any of these symptoms. And then some other signs and symptoms that I just wanted to kind of point out. These ones I wouldn't say are stroke specific, but I would still encourage you to go to the hospital if you're having these symptoms, unless obviously it's something that you have been experiencing. So, not necessarily like numbness. People can have numbness for multiple different conditions. And if it's something that you obviously know about, then obviously that's like normal for you. But if it's new and not something that normally happens for you, then obviously it's probably time to get to the hospital and get checked out. And then confusion, that one kind of goes with the speech problems, I would say. But a lot of times in the hospital, we'll ask like their name, what month it is, what day of the week it is, what year it is, like questions like that, that they should be able to answer. And if they're not able to, then that is a very concerning sign. There can be vision problems, trouble walking, so like unsteadiness, or a severe headache that doesn't go away. And those, a severe headache, a lot of times we would consider like a thunderclap headache. It comes on the suddenly, the pain is extremely intense right away, and that's a more of a sign of a bleed than an ischemic stroke, but again, still a stroke and still important to get to the hospital. So today I've mainly wanted to focus on risk factors and prevention, and but again, maybe some other time we can go into more depth of like the different kinds of stroke, or the what you can see with different types of strokes in different areas of the brain, ischemic and hemorrhagic. But again, this risk factors and prevention is going to focus on ischemic risk factors and prevention, but some of them do cross over with, obviously, if you live a healthy lifestyle, that'll still help prevent hemorrhagic strokes, but there are also different specific things for hemorrhagic stroke that sometime we can talk about in the future for risk factors and prevention. So we'll start with our non-modifiable. So non-modifiable just means things that we cannot change. So those are going to be age, sex, low birth weight, race and ethnicity, and then genetic factors. So for age, your risk for ischemic stroke doubles each consecutive decade after age 55. And then for sex, the risk of stroke is 1.25 times higher in men than women. But that's also, so sex is definitely based on like biological sex and not gender identity, because it's going to change depending on if someone's taking like hormone therapy, or there's going to be more factors involved. So sex, you can't look at just sex by itself. You also have to take into consideration all the other factors that are involved in that too. But just the basics are that it's going to be 1.25 times higher in men than women. And then we'll go on to modifiable. So those are risk factors that you can change in theory. Obviously, on here we have diabetes. So if you have type 1 diabetes, you can't change that. But there are ways that you can help prevent stroke even with diabetes. So modifiable actions, I guess you could say. And I'm going to go more into depth on all these, but those are blood pressure, smoking, diabetes, dyslipidemia, AFib, carotid artery stenosis, postmenopausal hormone therapy, oral contraceptives, diet and nutrition, physical inactivity, and then obesity/fat distribution. So we'll start with high blood pressure. So that is going to be the most common risk factor. So, Katie, if you had to guess, how many adults older than 20 do you think have hypertension? If you had to get
Mm,
a
I would
percentage.
say like maybe 65%. That'd be my
Oh,
guess.
it's actually 33%.
Oh wow, that's a lot. I'm
But
gonna put
if you had to
that.
guess how many of them are adequately controlled, like have it managed, what percentage do you think that would be?
Like of the 33%,
Yes,
how
yeah,
many? I would say like I don't know, maybe 50%.
that's correct. Yes. 50%, only about 50% have it adequately controlled, their high blood pressure. So I did try to turn that into numbers, and with some, I think the US Census Bureau, I just tried, but I also wasn't able, how they categorize it is they have like 18 and older. So they didn't have like a 20 and older option. So these numbers might not be completely accurate, but I got around, that means 66.3 million Americans have high blood pressure. And then only 30 or 33.2 million of those 63.3 million are adequately controlled, and then the others aren't. So that's still a big number of people.
Yeah.
So I was just going to talk about some other things. So lowering blood pressure is the most important modifiable risk factor. And then there are different, I think I talk about, yeah. So here we talk about kind of ways that you can adjust your blood pressure. So normal blood pressure is going to be less than 120 over 80. And then ways that you can help lower your blood pressure are going to be weight loss, smoking cessation, diet. So either heart healthy or a Mediterranean diet is what the doctors that I used to work with would always recommend to patients. Increasing physical activity, limiting alcohol. So that'd be less than one drink a day for women, or less than or equal to one drink a day for women, and then less than or equal to two drinks a day per man for men.
Now, can I save up those 7 drinks and drink them all in one day a week, or is that going to be bad for me for my
that
blood pressure?
that that would be bad. That
Okay.
yeah, so it's you can't that is not something that you can kind of save up in a sense. You have to it kind of resets each day. So
Okay.
if you don't drink, if you didn't drink yesterday, that doesn't mean you can have two drinks today. That means that
Yeah.
you can only have less than or equal to one today as well.
Okay.
And then there's also self measurement slash monitoring. So at home blood pressure monitoring. And with that, it is important to obtain accurate blood pressure measurements and classify based on an average of at least two readings obtained at two different points in time. So, one thing that I was always told is that it's good if you take it pretty much right away in the morning when you get up and then before bedtime. And then take that maybe for a week or so and then kind of see what the average is. And then that should give you your approximate blood pressure. And then, obviously, other treatment, if your blood pressure is high, there can be medications that you can take as well, but you'll have to work with your doctor on managing blood pressure with medications. So, that was what I had for blood pressure. And then, smoking. So, Katie, what
Mhm.
percentage of people age 18 and older do you think smoke cigarettes? So, not vape, just cigarettes.
Just cigarettes?
Yes, 18 and older.
Mm, I guess like 40%. I don't know if it's that
Okay.
high, but that would be my guess. Because I met a lot of people who smoke cigarettes.
So it's from the data I got, or not that the data that I read, it was about 14%. So
Well, that's good.
yeah, that's
I
still
mean, it's not great, but
high,
it's
but it's better than what I guess, and even I would have thought it was higher. But I do think our society is like
well, I
smoking is
think,
becoming less common, I would say.
yeah. Well, I think younger, like people around our age and younger, like they kind of vape more than they smoke cigarettes. Like cigarettes aren't really cool
Yeah,
anymore, you know,
yeah. And like
even from when
since
we were in high school.
and there's like a lot of different kinds of like there's obviously they have flavored vapes, but then there's also like I think they even have like different like what are those? I forget what it's called. Not vitamin vape. Well, I think they have some
Yeah, they
vitamin
have like
vapes, but
herbal vapes
obviously,
and stuff
yeah,
like that.
herbal vapes. That's what I was
Yeah,
gonna
I've used
say.
those before.
But those obviously I'm not talking about those. Those you'll have to look into to kind of see the ingredients and how those are going to
Mhm.
affect you. When we're talking about cigarette smoke, I think the main thing is like the nicotine and then the
Well, everything else they add into it too.
yes, that too. But how many so another statistic, percentage of adults that you think use e-cigarettes approximately.
Oh, if that's 14, maybe like 20%. Or maybe like
So
10, I don't know.
so I got 3.2%
Oh, that's it?
in the thing that I read. Yes, but how many of high school students do you think approximately?
Like, is this have ever vaped or is this vape on a regular basis?
It just said use e-cigarettes, so I guess it didn't specify if it
Um,
meant regular
well,
basis or maybe just like once or
okay. I think if it's on a regular basis, I would think it would be close to the 14% of adults. Maybe like 15% or something, 15 to 20. If it's kids who've ever vaped, I would think it'd be higher, like 40 or 50%.
so I got 11.3%. So it's close to that 14%.
Yeah.
And that's still high, especially for like just a high school student age
Yeah.
range. But Yeah. So those are just some statistics of how many people are smoking still. And then why some people may wonder why is smoking bad? And that's cuz smoking can narrow your arteries. So as we talked about, the blood ischemic strokes happen because the blood flow isn't able to get to your brain. So when you smoke, that's going to make your narrow your arteries, so make them smaller. So it makes it even harder for the blood to get there, and that you're going to have less blood flow as well, decreased blood flow. So then even if there's like a little clot, it can get blocked easier than compared to not smoking and not having narrow arteries. And there's obviously other causes of narrow arteries too, but that is one thing that smoking can do. And then smoking also can increase your heart rate and increase blood pressure. And as we just talked about, high blood pressure is also a very big risk factor for stroke. And then, so cigarette smoking can double your ischemic risk of stroke, and it actually contributes to 12 to 14% of stroke deaths. E-cigarettes are linked with a 71% higher risk of having a stroke, and the reason that e-cigarettes have that higher percentage risk is because they cause platelet aggregation. So platelet aggregation is when platelets kind of start to stick together, which can lead to blocking those arteries. And then that is also why you may see more younger people having increase, like seeing more young people having strokes because e-cigarettes, because more young people are using those compared to traditional smoking. And then, so kind of treatment, I guess, for smoking would be smoking cessation. And there's a bunch of different ways that you can kind of attempt that. So there's fading, where you slowly reduce how much, I think nicotine is the main thing, but basically just how many cigarettes you're smoking. And then there's replacement. So there's different forms of replacement that you can use. And then there's some prescription medications as well that your doctor may be able to prescribe you to help you quit smoking as well. And then we'll go to diabetes. So, Katie, how
Mhm.
many Americans do you think have diabetes?
I've looked this up
Both
like
types.
years ago. I don't remember though, so I'm gonna maybe like, is this type 1 and type 2?
Yes. And
Maybe like
so,
3% of people?
okay, I actually don't have a percentage for this one. It's nearly 1 in 10 Americans. So I guess is
Oh,
that
gotta be 10%.
10%? Okay.
That many
Math.
people have diabetes? Dang.
Yes. And approximately 1 in 3 American adults have pre-diabetes.
Yeah, I believe that.
So, again, why is diabetes a concern? It's because chronic hyperglycemia, so chronic high blood sugar, can lead to systemic inflammation, which can lead to arterial stiffness, damaging endothelial cells, resulting in atherosclerosis. So basically, that high blood sugar can lead to inflammation, which can then make your arteries more stiff, which again makes it harder for that blood flow to get through to your brain or any tissue really. But with when we're talking about strokes, we're talking about the brain. So it's hard for the blood flow to get through to the brain. And then it also can cause atherosclerosis, which is kind of just like when your arteries narrow, so making it even thinner. And not thinner, but just narrowing, like making it smaller, like making the arteries even smaller. So less blood also ends up getting through, and it makes it easier if even a small clot lodges in there, it can stop all the blood flow from going through. So another statistic, or not statistic, but fact here is that diabetes and hypertension double your risk of stroke. And approximately 74% of diabetes patients also have hypertension, so high blood pressure as well. So for diabetes, the main, I guess, prevention would be management of diabetes. And that's going to be glucose control. So getting your A1C checked frequently, keeping that in the range that your doctor and you have talked about. blood pressure control, as we talked about, and then there's obviously some medications that some diabetics can use too to help manage. And then I would say most of prevention for all of these kind of go together because a prevention method for blood pressure could also help with diabetes and all of them basically. So the main ones are like diet, weight loss, physical activity, and then limiting alcohol use. And the reason weight loss can help with diabetes is it improves insulin action and fasting blood glucose levels. And then physical activity, the reason it can help is because it increases insulin sensitivity and glucose control as well. So that was diabetes. Then we'll go to dyslipidemia.
I have no idea what that is.
So dyslipidemia is elevated cholesterol.
Oh, okay.
Or
Well, that
the
makes sense for the
and also
lipids.
be so dyslipidemia is, I think, if we think about dys, I think like DYS, that abbreviation, I believe it's more, I don't think it necessarily means high because that's hyper, but it kind of means like I don't know how to explain, like a
Like not
dysregulation.
where it needs to be.
Yeah, like dysregulation, whatever
Dysregulation.
that word
Yeah.
means, but
Yeah.
with your
Okay.
cholesterol. So that can also be like a low HDL cholesterol. So it's not necessarily only high cholesterol. It also depends on the specific cholesterol. Like if you have a low HDL cholesterol, because HDL is the good cholesterol. And the way that I remember because there's HDL cholesterol and LDL cholesterol. So the way that I kind of memorized which one was good and bad was that I think of HDL as high definition and then LDL as low definition. Because when we're watching something, we want to see it in high definition. And so that's a good thing. So HDL is good and LDL is bad. I mean, neither of them are necessarily 100% good or bad, but that is just how I kind of memorized it. So, but elevated total cholesterol and low HDL cholesterol are risk factors for ischemic stroke. And about 53% of American adults have high LDL cholesterol, and then less than 50% of those are on treatment.
Oh wow.
Yeah. So, again,
That's more than I thought.
a lot of times what I've learned when I was looking into this is that people, and again, that can come down to a multiple different reasons why people either can't or aren't treating, but a lot of things does come down to like treatment is seems to be lacking, which also can then explain increasing strokes if that is happening too. um but so then treatment for dyslipidemia is gonna again mainly be diet and medication. But yeah, I think that's all I had on dyslipidemia then,
Okay.
because those trans fat and fried foods are what are going to get, and that's the American diet. But we'll talk about diet in a little bit. So then we have AFib. So for AFib, we'll talk about the risk. So it is so I guess, do you know what AFib is? Kind of.
That's isn't that like a regular heartbeat,
Yes. So
like non-rhythmic?
yes. It's when your heart isn't really, like the electricity communication isn't really working that well. So then it leads to irregularities in the normal rhythm of your heart. And the reason that that can increase your risk of stroke is because it can so in a way, in a sense, it can kind of lead to quivering of your heart just because the electricity is still going through, but it's almost happening too frequently. And then it just kind of leads to like blood pooling as well, which blood pooling can lead to clots. So the biggest thing with AFib is that it can lead to clots, which can then get shot out into the bloodstream, and that can cause any type of either stroke or like a blood clot anywhere really. But when it comes to strokes, we're talking about the brain again. So that can push a clot up into the arteries of your brain, causing a blockage, leading to blood flow not being able to get to your brain. So for AFib, that can cause like a 4 to fold elevated risk of stroke, and AFib is also associated with increased mortality. And it causes about 15% of strokes per year, and estimated 2.7 to 6.1 million Americans diagnosed with it. So, treatment for AFib is going to be obviously dependent on like the patient and condition and all that, but a lot of time or sometimes they'll do rate and rhythm control, but that doesn't directly affect stroke risk rate. So that can be good for the patient depending on the reasoning and like that obviously whatever the doctor wants to do, but that doesn't necessarily 100% decrease your risk of having a stroke due to AFib. So another option that they can always do is like anticoagulation. So that's going to be blood thinners. It just helps prevent clotting. There's a bunch of different kinds of anticoagulation treatments, but they prevent thromboembolism, which again helps decrease that risk of stroke. And then some other treatments that I saw was to decrease or eliminate caffeine. And then adequate hydration, I saw. And then home safety to prevent falls. But I think that one is more so like that one you should always just think about for anything. But I think when you're on anticoagulation, that can increase your risk of bleeding. So you don't want to, because a lot of times with AFib, you are going to be on some anticoagulant and you don't want to, you want to make your home safe so that you don't have a fall and then bleed. Because that can also lead to a brain bleed, which is the other type, the hemorrhagic stroke. But, and then on a certain medication, warfarin, there is going to be diet restrictions. So you want to maintain a certain level of vitamin K. So before you start taking it, if you're eating vitamin K rich foods, which a lot of times are green leafy vegetables, so like spinach, stuff like that, then you want to, if you start warfarin, you want to keep that same amount. So don't increase how much vitamin K rich foods you're eating and don't decrease it because that can affect the level of warfarin in your blood. But that is something that your doctor should also kind of educate and work with you on as well. And then we have carotid artery stenosis. So, do you know, Katie, do you know where our carotid arteries are?
I have no freaking clue.
Okay. So, those are the ones in your neck.
Oh, okay.
Yes. So, the
Got it.
reason that that's a big factor for stroke risk is because stenosis is kind of, I think, I want to say like thickening or block it. Like, they get stenosis. Like, I know what stenosis, like, it's hard to explain what stenosis is per se, but it's more like what did I say earlier? Stiffening kind of, I want to say. Like they get stiffer and harder again for blood flow to go through. And that can be due to a blockage or anything, but so carotid stenosis is responsible for 20 to 25% of ischemic strokes. And some risk factors that can lead to the stenosing of the carotid arteries are cholesterol, so having high cholesterol, diet, and if your diet is high in saturated or trans fats, smoking, overweight, obesity, sedentary, hypertension, insulin resistance, diabetes, metabolic syndrome, age, and genetics. So, a lot of those symptoms are risk factors that can cause, I would say, any of these can also end up leading to a stroke. So, they're all kind of connected in a way, too. And treatment for carotid artery stenosis is going to depend on the severity of it as well. But some treatments is lifestyle. So diet wise, if you follow a low fat, low salt diet, or again, a Mediterranean diet, there are some medications, and not only specifically for stenosis, but to treat the other underlying conditions like diabetes, high blood pressure, etc. Because again, since those can cause carotid artery stenosis, we also want to treat and maintain those conditions as well. And then for carotid artery stenosis, if it's bad enough, there are also, or if the doctors think it would be in your best interest, there are also some surgical interventions. And that can be a carotid endarterectomy, which is just surgical removal of the plaque, or carotid artery stenting, which is when they go in and place a stent in your vessel to expand and maintain blood flow through the artery. And then we'll talk about hormone replacement and specifically postmenopausal hormone replacement therapy. So we're going to talk about risk, and the risk for ischemic stroke doubles in women after menopause. And use of hormone therapy increases relative risk of ischemic stroke. So estrogen-only hormone therapy is associated with increased stroke risk, and higher estrogen dosage is going to increase that risk further. So estrogen, the more estrogen that you use, in a sense, is going to increase your risk of stroke. And then another option that some people may use is transdermal estrogen, but that has a lower risk of stroke because of avoidance of liver metabolism. Because liver metabolism with these medications increase your coagulation, but since you're avoiding that metabolism with a transdermal estrogen, it doesn't necessarily increase your risk. And then there's combined estrogen / progestin hormone therapy, and that's associated with highest risk. So then some mainly I would say the treatment for this is going to be like your life, like you can diet, exercise, but a lot of times it's going to be lifestyle changes to combat menopausal symptoms if you're trying to avoid, or if your doctor doesn't necessarily think it would be best for you to be on hormone replacement therapy, depending on other risk factors you may have. But some lifestyle changes that you could consider that may help with postmenopausal symptoms are going to be lighter clothing, sleeping in a cooler room, decreasing stress. So that can be meditation, mindfulness training, yoga, avoid spicy foods and caffeine, limit alcohol intake, plenty of rest, physical activity early in the morning and not late in the evening, and then a hot shower or bath before bedtime. And then the next risk factor is going to be oral contraceptives. So the risk of stroke in non-pregnant young women using oral contraceptives is lower when compared with pregnant women, but there's a 1.6-fold higher increase in women using oral contraceptives compared with women who do not use oral contraceptives. So the risk is lower when using oral contraceptives compared to being pregnant, but compared to someone who's not pregnant and not using oral contraceptives, the person using oral contraceptives risk is going to be higher. So risk of stroke increases as estrogen dosage increases, just as we talked about previously. And then there's no increased risk of stroke with progestin only oral contraceptives. And then it's also, for some women using oral contraceptives, they may have a higher risk. There are some factors that can increase your risk, and that is being older than 35, if you're a smoker, have hypertension, diabetes, if you have migraine with aurora, hypercholesterolemia, obesity, and or prothrombin mutation. So genetic factors can also increase your risk if you're taking oral contraceptives. Use of non-estrogen contraception, such as intrauterine device, is recommended for women with multiple stroke risk factors. So that is, again, something that you'll want to have a conversation with your doctor to see what would be the best option for you. And then if you do end up taking the estrogen oral contraceptives, some things that you can do to try to help lower your risk or kind of prevent it is smoking cessation, blood pressure control, cholesterol, blood sugar control, weight loss, and increased physical activity. So, again, kind of the things that help prevent all these other factors help prevent this one as well. And then we got diet and nutrition. So we'll go over just some importance and facts again here. So increased risk of stroke is associated with low intake of potassium, low intake of fruits and vegetables, low intake of fiber, and then a high intake of sugar, which is kind of the American, like opposite of the American diet. So that is why it's important to try to, if you can, edit your diet. And then Mediterranean diet reduces stroke risk by 22% in women and 6% among men older than 40. And the reason that Mediterranean diet has been shown to help is because it can have reductions in blood pressure, lipids, and the inflammatory processes, and overall improvement in metabolic health. So Mediterranean diet is something I would definitely recommend looking into if you can, and maybe trying it out sometime, because it is extremely helpful in helping lower your risk of having a stroke and other things as well, just because it's a good, healthy diet. And some other things under diet that I found was 3 to 5 cups of coffee per day can help decrease cardiovascular risk. And obviously, as we mentioned earlier, there are some times where you want to limit caffeine depending on, like, for AFib. And I think for postmenopausal symptoms, you also want to limit caffeine, but regular and decaf coffee provide equal benefit. So you don't have to drink regular coffee. You can drink decaf coffee, and that should also help lower your risk, or may help with the cardiovascular risks. And then green and black tea can also help reduce cardiovascular risk. But again, it depends on if you can have caffeine or if you shouldn't have caffeine. Intake of sweetened beverages, so sugary beverages, is associated with a 16% increase in stroke risk. And then another thing that could help is increasing sleep duration may improve insulin sensitivity and dietary intake. So getting the appropriate amount of sleep is also very important. And then we're going to talk about physical inactivity. So for that, I found getting more steps in during the day was associated with decreased mortality. And the thing that I saw, it said getting about 4,400 steps in a day was associated with a 41% lower mortality compared with those who got approximately 2,700 steps in a day. So even just increasing your steps by not even 2,000, but about 2,000, like, I don't know the exact math on that, but even just increasing your steps by about 2,000 can really help lower the risk of mortality. And for me, one thing that I've been doing lately is just setting like a timer on my Apple Watch, or it could be on your phone or anything, and just pacing around my house, just because I know that with us doing obviously the podcast and then some of the other things I do, I'm very sedentary. So I know that I need to somehow get steps in. And for me, I just figure I can take 15 minutes out of an hour or a couple times a day to try to get those steps in. So however you can try to fit those steps in, maybe if your job, you could get up and just kind of pace around the office or whatever it is for a little bit, for 15 minutes, a couple of times a day, anything to help increase your steps. Again, they said 4,400 is what they saw was associated with 41% lower mortality. I think it also said, I don't think it showed too much improvement with getting like a lot more steps in compared to that. So even if you can just aim for like that 4,400-ish a day, that is really going to be beneficial for you. And then also regular physical activity may help reduce risk by 25 to 30%. And the reason, so why that can help for different reasons. So if you have hypertension and exercise, that can help decrease arterial stiffness and reduce your systolic blood pressure, so the top number. For hyperlipidemia, exercise can increase the HDL, so the good cholesterol. It can decrease that LDL, so the bad cholesterol. It can decrease total cholesterol and decrease your triglycerides. For diabetes, exercise can help with decreased insulin resistance and improved glycemic control. For obesity, exercise can help decrease weight, BMI, and waist circumference. And then also exercise may exert a neuroprotective effect, improve neuroplasticity, and brain repair. And the recommendation that I saw was approximately 40 minutes of moderate to vigorous intensity exercise 3 days a week. But I know that isn't always going to be the easiest for everyone to fit in. So even if you can do like 10 minutes a day 4 times a week, or maybe like 20 minutes a couple of times, like whatever, however you can fit it in. And there's going to be different recommendations too. Like I think all the different, like the Stroke Association and the cardiology, so like the Heart Association probably has, maybe, I feel like they're going to be pretty similar, but they may be a little different. So I would just kind of look into, and obviously if physical activity, we can't just jump right into 40 minutes of moderate to vigorous, so you kind of have to build up your tolerance in a way, because you don't want to strain yourself either, because that isn't going to help you, because then that will just prevent you from exercising and make it worse for you. So you want to kind of slowly build up to the goal, however you're able to do that. And then I think the last one I had here was obesity slash fat distribution. So obesity disrupts lipid and glucose metabolism and the inflammatory response. And then I saw some, I guess, little statistics here. So for every 1 unit, which is approximately 7 pounds, increase in BMI, your risk for an ischemic stroke increases by 5%. But there are obviously some limitations of the BMI. Some of those are it overestimates body fat in athletes who have a muscular build, and then it also underestimates body fat in older people who have lost muscle. And then it actually said that abdominal adiposity is a more accurate measurement of stroke risk and indicator of metabolic health. So for that one, there were some statistics of that too, and it was if there's a 10 centimeter increase in waist circumference, that was associated with a 10% increase in stroke risk. If there is a 0.1 unit increase in waist to hip ratio, that was associated with a 16% increase. And then a 0.05 unit increase in waist to height ratio was associated with a 13% increase. So it's going to kind of depend on which measurement you are using that can obviously affect your risk. But basically, an increase in any of those is going to increase your risk of ischemic stroke. But obviously, in, I would say, our society, there are going to be some things that are going to influence our ability to be able to affect this. And some of those are non-walkable cities, safety risks, especially for big cities, abundance of high caloric foods, the fast food industry influence, and then genetic factors. And it said that genetic factors may affect about 25 to 70% of body mass or body fat. So I guess for that one, I would say I wouldn't let it. I would obviously focusing on all factors is important if you can, but I wouldn't let one factor kind of control your life and trying to control that one risk factor. Because again, if there's a genetic reasoning, it might not be something that you can easily or even actually adjust. So,
Yeah, I think one more, um, I guess, cause of obesity, if you will, or like risk factor for obesity. I think like certain medications also have.
oh, yes. Yeah. And there's a bunch. Yeah. So there's a bunch of like things that can affect it. And obviously, I would just say our society, just the work nonstop. So then you have to go to which I guess the fast food influence industry influence is what that meant. But it just, and then the food deserts, as you mentioned,
Yeah.
like before, I think before we started recording, but food deserts as well is gonna. So it's really like that one is hard to control. I would say just due to so many factors. So I wouldn't. It's still important, and if you are able, like exercise, I would say is still going to be the most beneficial to affect this, but it's not something that we always 100% have control over either. So I wouldn't. I know this is technically still a modifiable one, but there are going to be with any of these modifiable factors, even diabetes. Like if you have type 1 diabetes, then it kind of is a non modifiable, but you can do management. So management is going to be probably the most helpful thing you can do in some of these cases as well, I would say. But yeah, otherwise, I think that was it. So let me, we can go to questions, but I'm going to get out of this screen and stop sharing.
Mm.
Okay.
Okay, awesome. I just have a couple questions here.
Okay.
First one, what are the main symptoms that are a consequence of stroke? So, like after you have a stroke, what symptoms might you see?
Oh, sorry, you froze on me. What'd you,
Oh, yeah, I can repeat myself.
okay.
So what are the main symptoms that are a consequence of stroke? So after you have a stroke, what symptoms might you see?
So it's going to kind of depend on the severity. Because as I was a neuro nurse, I saw kind of a wide range of differences. So some people could be completely fine, and then others would be completely debilitated. It just honestly depends on the location of the stroke. It depends on how quickly you were able to get to the hospital and how quickly we were able to start treatment. A lot of times, so there were amazing cases where we could see complete recovery. There would be no deficits at all. But then there would be times where patients weren't able to talk anymore. Like they weren't able to have conversations with us. They weren't able to walk. They weren't able to even like use their hands anymore. So it can be very debilitating and just very completely depending on what kind of stroke you have, where that stroke is, and again, how quickly you can get treatment started. And even like, even sometimes if you get to the hospital right away, it depends again on where the location is and if it's a hard to treat stroke or if it's somewhere that we can easily get to in a sense. So it kind of depends on, I would say the biggest factor, I mean, all of them are important, but I would say one of the biggest factors is location because that's going to depend on or determine what treatment options we have. And that's going to be a big factor on, and that isn't anything that anybody controls. So don't, like, I don't think anybody should necessarily stress about trying to control specifically where you, because your stroke can happen anywhere and it can happen to anyone. So that's not anything like, I don't like that would never be someone's fault, I guess. Like that is just something
Mm.
that is unfortunate and it happens.
Okay. Then what kind of cures or treatments are there for stroke victims?
So it, that also kind of depends on like the location and where it is, but I know the biggest thing I would say that I always saw with patients after is going to be like therapy. So whether that's physical therapy, speech therapy, or occupational therapy, working with therapy and trying to increase, like get up and walk if you're able to, or like if you're able to like use your hands and feed yourself, and even if it takes a while, that's okay. It's better to, what I think, I don't know if we were told this in stroke, but I feel like it applies to stroke. I feel like it applies to everything in your brain, because obviously, in a sense, our brain is like use it or lose it. Because if you're not
Mhm.
using these pathways in our brain, then your brain isn't gonna necessarily focus on, especially if you have an insult or injury, it's gonna focus on the pathways that you're using more and kind of try to build those networks and connections again.
Yeah.
So it kind of depends, but therapy is going to be the biggest thing. There are sometimes, I think, obviously medications, but a lot of those are more so, again, to treat risk factors. Like, as far as I know, there isn't anything that, I mean, maybe like anticoagulation, but again, that's more to treat the risk factor of clots rather than like the stroke. Because once you have a stroke, you've had the stroke. So then
Okay.
it's more so treat. So there's not really a cure either, because it's, I don't know, it's, I guess maybe if you consider full recovery a cure,
Because
but
it's like a medical event. Like it happens and
yes,
then it's gone.
yes, yeah. It's just an event. It's just some like, because the debilitating effects are caused by the stroke, but you're not having the stroke anymore. It's just the effects, the after effects in a sense. But again, therapy is really good. And then sometime, not today, obviously, but sometime we should go into neuroplasticity, because that
Oh yeah, definitely.
there that has been
That's super
shown
interesting to me.
to, that can, like, some people, I read a book on it, and I'm not, I don't, I obviously feel like they weren't lying, but they could have been. I don't know. I'd have to look more into it. But basically, their father had a stroke, and he had lost complete, I think, ability to do anything. So then the writer of the book was able to basically retrain his father's, which took a lot of time. So it's nothing that happened overnight. Like, it took years.
Yeah.
But he was able to help his father learn to walk and talk again and everything. So that's amazing how the brain, because I feel like before we would always assume like once you've had these defects, you have them for life. But I think with neuroplasticity, we've kind of shown that you can start to gain some function back. Not, maybe not all function. I don't know. We'd have to kind of see where the research on neuroplasticity, what that research shows us in the future. But I wouldn't be, because it. I don't know. I need to look more into it, but before I talk too much about it. But I'm really interested in it because it's amazing, especially like working with stroke victims, patients. It's just amazing to, I guess, have hope and believe that they will be able to gain that function, or at least some of that function back.
Hmm.
Especially, it's just a very debilitating disease. So
Yeah. Okay. And okay, I have one last question here.
yes.
So when you're treating stroke victims, what's that experience like? And then what can you say anything about their experience maybe?
So it's gonna vary per patient. Obviously, the probably easiest cases are gonna be the ones wherein, for me, I was working on like the floor. I would like, not ICU, neuro ICU, when I was working in our neuro floor unit. Those were probably, they would still sometimes have a lot of debilitating problems, but then you would also have the ones who had no debilitation. So I would say that was better in a sense sometimes, and a lot of times it was great because then they could work with you, and uh, at least some of them could understand, or like family could be there a lot of the times and help them either with eating or trying to get them up and walking as well. Obviously, anytime on the neuro unit, we always made sure that a nurse was there, because with stroke victims, patients, there can be a lot of falls. So, which can lead to even more complications. So we always wanted nurses to be around. Even if we knew the patient could walk well, we just felt safer having a nurse around. And a lot of people understood that and respected that. So I would say that was good about working on the floor. And again, the experience for the patient depended on where the stroke was and how much the stroke affected them. Because again, it could be they were almost independent, could get up and walk, but we still obviously keep, even if they had like a TIA, which is a trans ischemic attack. It's like a, not a, I don't know. Some people would call it basically how I always thought of it was like you had a blockage, but the blockage resolved itself. So like you did have a stroke, but like your body in a sense fixed itself. Like whether the blockage opened up, whatever it was, it kind of fixed itself. But you still have to be monitored for, I think it was at least 24 hours. So even if you all your symptoms resolved, we still kept you just to make sure that it didn't happen again. Because I think once you've had a stroke, your risk for stroke increase. I'd have to look into the
I
statistics
think
of
that is
that,
true.
but
I think I have heard that before.
yeah. So we always kept you just to make sure that, and then obviously for life, it's always just something that you're going to have to keep an eye out on. But so again, they could either be up walking, talking, doing all that, or they could, like sometimes if it was just the right leg that they had lost weakness to, they would obviously need help getting up and walking to the bathroom. Or if it was their arms, like maybe one arm was weak, and if it was their dominant arm, they may need help with eating. So that just kind of depended on the disability, how much the stroke debilitated them. But then there was the ICU, and that was hard for just a lot of reasons. But a lot of times those patients would have to be intubated, and so they couldn't do much anything for themselves. And then just having those conversations with families was never easy. And just like the disability in the ICU was never great to see. But then there also were cases there where they did improve and were able to kind of move to the floor, so that was amazing to see. So there again, it just kind of depended. So a lot of times it's going to depend on, and it's going to depend on what kind of stroke. So it's not only where the stroke is, but it's going to depend on if it's an ischemic versus a bleed too. That's definitely gonna, we'll talk about bleeds sometime because those are very interesting too. Like we'll go into depth sometime on bleeds, I think. So yeah, it's going to kind of depend on what kind of stroke and where that stroke is. That's really going to affect a patient and their experience too. Because obviously, being intubated is not fun for anyone. So that's just not a good situation at all. But then the ones who come in and are able to walk, I mean, they may not like being hospitalized because I don't think anyone necessarily likes being in the hospital, but at least they still have their fund. But they are going to have other concerns. Obviously, anyone who's hospitalized, like payment and obviously health insurance, all that stupid money stuff. But from the experience of the stroke, at least they can walk. But it's still going to be a big thing that's going to affect them because, again, that's going to increase your future chance of having one. So it's still a big change. It's still, like, as we talked about grief, I would say it's still a big, like, you should still process it. You shouldn't just be like, oh, I'm 100% fine. Like, because you
Right.
still had a life changing event, like a medical event, like a medical emergency. You still went through
Mhm.
a medical emergency. So you still should process that in.
Yeah, it's definitely important to grieve when you
Yes.
lose part of your health.
Yeah. Even if you regain all your function and don't, and are like, oh, well, the stroke didn't affect me, it's still
It's
like,
gonna
it's
be
still
traumatic.
because, yes. And your, again, your chance of having it again is gonna increase. So sure, you may be fine this time, but if it happens again, you may not be next time. So it's definitely the big thing I would recommend in that process is going over risk factors. Because
Because
I think all stroke hospitals have to have like an education booklet to educate on stroke, which or maybe they don't, I don't know. We had one. So we had to go through this booklet that we could kind of help the patients see, oh, what are my risk factors and what can I do to kind of help prevent these or improve these risk factors. So that time is super important. I know again, you just went through a medical emergency, so it's like probably hard to even want to focus on what can I do to help prevent it from happening again, but that is one of the most important times to focus on what can I do to help prevent this from happening again.
So is stress also a risk factor for stroke, or does stress not affect stroke as much?
I'd have to look into it, but I almost feel like
I think it
it
would.
can. Yeah.
I would
Because
think.
I think if you, let's say you're vaping or smoking and then start having a panic attack,
Mhm.
I'd have to look into the physiological effects of like the stress response, which I do want to look into, but I almost feel like that can cause, because like when you go into fight or flight, it's going to shunt blood vessels to certain areas. So if you already
Mhm.
have narrowed arteries, I feel like it could narrow them even more to where like you're at even, I don't want to say that to like scare anyone who maybe experiences bad panic attack. Like, no, that's not, it's just,
Yeah.
I do think that that can definitely cause, like, be a factor
Yeah.
too.
And not even
But
just
I want to look
panic
more into
attacks.
that too.
Like, I would say, like, angry outbursts or just bottling in the
Yeah,
stress, even.
because even that,
I feel
even
like
like an
bottling the
angry
stress would be the
outburst,
worst.
angry emotions can raise our blood pressure. As
Mm.
like even patients' family members when they're dealing like grief, like just that anger that may happen during grief, you're
Mhm.
gonna have anger, and then that can raise your blood pressure. And if your blood pressure is already high, or maybe your blood pressure is normal, but you have other risk factors, so and that's just in general, not even just for like because that can like maybe your heart, if there's a clot there or your arteries are narrowed on your heart, maybe that could lead to like an MI or something, like a heart attack. So I think stress as itself is a big risk factor for a lot of, and even the immune response diseases. I feel like sometimes stress can kind of lead to those in a sense. But it's also hard because our society has almost built like its structure around stress. Like you
Yeah.
feel like we always are stressed. Like you have to be working a 9 to 5, and then you come home, and then you have to cook, and then you have to clean, and then you have to get ready for tomorrow's workday, and then you have what 2 days off on the weekend. But if you have a family and kids, you may have a bunch of other things, and even just
And
for
you just
people who
need
don't
time
have
to
kids,
process the day too. Like,
yeah, and
that's
even
something
people who don't
people
have
don't think
kids, like you
about.
still have to do laundry and cleaning your house,
Yeah.
and just it's ridiculous what we've built a society around. It's
Yeah.
crazy. Like we've built a society around disease. It's just
Yeah. I mean, well, corporations profit off disease, so,
yeah, they yeah,
it definitely helps them out.
which is sad, but
Yeah.
because
It's just a
nobody
big loop
deserves to
of
go through
destruction.
any, yeah, and nobody deserves to go through any of that.
Yeah.
It's not why we're here. It's not, at least that's my belief. We're here to live life and experience it, but not like this.
Yeah.
But that's just my philosophy, if you will.
Yeah. For
but
sure.
but yeah, I think that's, again, that was only mainly prevention and risk factors for ischemic. So sometime if other people want us to, or even I just want to, so even if you don't want to, Katie, I can always do that like
Okay.
as my
Yeah.
own video sometime. But I want to go because
I didn't feel
I
like I had much to contribute to the conversation. I don't know
no,
enough about
that's,
stroke.
but I feel like even, but that's why I also have tried to ask you those statistic questions
Yeah.
sometimes because I feel like that's fun to get you
Oh, yeah.
and just to kind of see like what you think. But I mean, yeah, but then because I used a lot of this, I learned when I was studying for my SCRN, so I would not even mind doing more, even more in depth, in case somebody has to or wants to study for like, obviously only if they feel like I'm a good teacher in a way, because otherwise it's not going to help them. But I'm also open to feedback and improving. Like if the slides, maybe if I should have had more, like I don't know, I'm open to feedback because I love teaching myself, and I feel like one way that anybody can help improve their own learning is to teach others.
Oh, for sure. Yeah.
So I will
100%.
definitely, and this PowerPoint I made kind of quickly. So it was,
Mhm.
if I had more time, I feel like I could have maybe drawn, like practice drawing my own illustrations and all that, which would be fun too. Because that would, I think for me, animations, I want to get into anime. Like I will try to figure it out, but feedback is always helpful too on what you guys think how we can improve our teaching too. Like maybe if um, you need us to do less talking and more examples or whatever it is, you let us know. Feedback is always encouraged because that's going to help us help you guys as well. But so sometime I do want to go more into depth about just all the strokes certified registered nurse information because again that will help me too. Even though I'm not actively practicing nursing, I still love to keep up to date in a way and keep my knowledge fresh and always improve it too. Always learn. Because even if I were to look through the book right now, there would probably be so much information that I don't actually know, or not that I don't know, but just that I don't have an in depth understanding of. That would be nice to learn for myself too and teach other people too. So sometime I will do that and we can
Okay.
do that too. Okay. But yeah, so you guys just let us know if there's ever anything we can improve, but also let us know like any other topics because obviously I said I want to go more into depth on this, but let us know any other topics that you guys want us to ever do on a Tuesday. Again, education mainly, but it can be anything. Just any topics for any day of the week. Let us know below in the comments.
Yeah, or you can also let us know on Facebook, Instagram, TikTok, Twitter, and we now also do some Twitch live streams.
So don't forget to like, subscribe, and turn on notifications so you can know when we do that because we'd love for you to join us and just kind of hang out and talk. But yeah, so don't forget to do that. And then we will see you next time.